بسم الله الرحمن الرحيم. تقبل الله طاعتكم وبارك عليكم شهر رمضان. وإن شاء الله يعود علينا بس بأوضاع أحسن على next year إن شاء الله. حابة أشكر نادي عبر ومنار الطبطبائي وأسماء اليحيوح اللي نظموا this Zoom meeting or lecture. مبادرة طيبة منهم جدا يعني وردة الفعل يعني ما شاء الله. أشكركم for leaving your TVs, your kitchens and coming to this lecture. Nice change. خلاص ملينا مسلسلات وملينا تلفزيون وأخبار تضيق الخلق فنغيرها شوي اليوم. Dysphagia is my new love and so I've decided let's do something different. Why not? I just thought, maybe more people would be interested in this. Clearly, yes, we do have a nice number today. So there are a lot of people that are interested in dysphagia. Unfortunately, so in the beginning, when I set up my lecture, I was hoping to cover the A to Z of dysphagia, يعني swallowing, normal swallowing and physiology. I wanted to do also to talk about dysphagia and then move on to the assessment and management of dysphagia. However, once I put together all of these slides and information, it was going to be more than 2 hours of talking. That's a lot. So I cut it in half, kind of. And so today, I will just pull up my notes. So this is the outline of my talk today. If there's anything, Manar, just send me a message or just give me a call on my phone. So this is the definition. We talked about this, the definition of dysphagia. We broke down the term dysphagia into the root and the prefix. Okay, so dysphagia is difficulty in swallowing, specifically. Tanner mentioned a very good definition. So, and I like to use his definition when it comes to my lectures. It's very comprehensive, and so it encompasses most of what we will be talking about today. Okay. So he says that dysphagia is an impairment of emotional, cognitive, sensory, and/or motor acts. Okay, so we know that there is the emotional and cognitive aspect that a lot of the times we overlook as, I think, as regular human beings, I think, not as clinicians. As clinicians, we're more aware of this, I think, but we need to educate the families about the emotional and cognitive aspect of any disorder. And dysphagia is no exception. So we do have, it's a ball of, or a basket of lots of problems. Okay, so it's an impairment of emotional, cognitive, as well as the sensory and motor acts of transferring the bolus or the substance that we are ingesting from the mouth to the stomach. Okay, and so it is not only the act of swallowing that is impaired, but also the emotional aspect of it. And that results in failure to maintain things like hydration, nutrition, because of the limited intake that dysphagia has on the patient. Ultimately, what dysphagia does is it poses a risk of not only choking, but also aspiration. Now, for those of you who are sort of first, second year students, I'm going to try to define every single term that may not sound familiar to you or difficult. And if you do have a question, you can just put it in the chat or wait till the end for me to answer it. Okay, so the prevalence of dysphagia. Typically, when we talk about the prevalence of dysphagia, we talk about it in terms of population settings. the prevalence of dysphagia in the general population, so if I go out and I take a bunch of people and I screen them for dysphagia, we'll find 16 to 23% of those individuals that have some kind of a swallowing problem, whether they know or don't know or not aware of it. 16 to 23%, a little bit high, I would think. But if we look at the age groups, now, once we hit the 70-year-old and above, we see the numbers go up. So 27% of individuals over the age of 75 will have some form of a dysphagia. And if we look at settings, so if I go into an acute ward in the hospital, for example, and I screen the patients there for dysphagia, I will find the numbers there to be much higher. So according to setting, again, which is the way we usually report dysphagia, we will find the numbers change. If I go to an aged care facility or a home, دار عجزة مثلا, and I screen them for dysphagia, I'm going to find the numbers to be much higher, because certain age groups and certain diagnoses play a role in how the or are more likely to demonstrate dysphagia or show dysphagia. Okay, so the elderly and specific groups, and we'll talk about that. So in the presence of neurological disease, and this is things like dementia, Parkinson's disease, stroke, multiple sclerosis, the prevalence will be much higher. So if you have a patient that comes to you and that patient has some form of neurodegenerative disease or diagnoses, then you are going to be looking for dysphagia. It's very likely that they will suffer from some form of dysphagia or swallowing problem or feeding problem. Towards the end, I'm going to just comment real quick about a study that my students and I did here in Kuwait, and it's involving Parkinson's disease. If I have time, I'll quickly run through it. But you need to be aware that a lot of individuals that do come to the clinic or go to, for example, the movement clinic or the neurology clinic with things like Parkinson's, we looked at patients with Parkinson's. A lot of them will suffer from some form of dysphagia and not know that they have some form of a, swallowing problem, or, it doesn't really register with them that this is a problem that needs to be fixed or managed. And so it goes unnoticed and underreported. So a lot of patients do not even report that they have some form of a swallowing problem. I'll leave that to the end about my study. The elderly population is, of course, at a higher risk. And that's why if we go to a geriatric care unit or a home or a nursing home, or دار عجزة مثلا هي عندنا, we find 60%, the studies have found that of individuals or patients residing in those settings had some kind of a feeding and swallowing problem, okay, or difficulty. So feeding is one thing and swallowing is one thing. To feed is to actually be able to eat. And the problem there could be to physically feed yourself, and to lack that ability because of paralysis أو شلل أو من نوع من الحركة اللي الشخص ما يقدر إنه يقوم فيها على أساس إنه يأكل. There could be a feeding problem and there could be a swallowing difficulty. And we find that there's a combination of those in that setting. Up to 87% in other cases, in other case studies have been reported. So the numbers are high, 60%, 87%. These are very high numbers that we find. High-risk groups, so these are individuals with specific diagnoses. Immediately, if you hold a chart, a medical chart, and you see some form of a central nervous system, peripheral nervous system, GI tract problem, things like head and neck cancer, a stroke, a traumatic brain injury, immediately you need to think about dysphagia, because these are the high-risk groups. Okay, prevalence in stroke is very high, especially in the acute phase of the stroke. So this is less than 5 days post-onset. Okay, so that means the patient is admitted into the hospital, they've had a stroke, it's been 5 days. This is the acute stage of the stroke. The chances are 50-50% that patient will have a dysphagia or a swallowing problem. 2 weeks onset, post-onset of the stroke, the number will drop. So you see that, some of them will probably, recover or have some form of recovery in their swallowing. And so the number will go down to 10 to 28% only. TBI, of course, because there's trauma to the brain, any insult to the brain, any damage to the brain, again, we will suspect dysphagia. The numbers here vary very much, and it depends, I guess, on the studies, but it's anywhere from 26 to 71%. It is quite high. I think it is more than 26% in my opinion. Dysphagia is typically looked at as a symptom. It's a symptom of something else that's happening, of an underlying condition. It could be a neurogenic disorder, so it could be a stroke, a TBI, traumatic brain injury, dementia, motor neuron disease, CP, Guillain-Barré syndrome, and any kind of neurodegenerative disease like Parkinson's and Huntington's and Wilson's disease. Dysphagia will come with this disorder, with any of these disorders. It's a symptom, okay? So it's a result of some of these diagnoses. You can also have structural diagnoses. So any tumor in the alimentary tract, so from the mouth all the way down to the stomach, if you have a tumor or cancerous growth that's happening, whether it's in the oral cavity, in the pharyngeal cavity, or the pharyngeal tract, down to the esophagus, even at the neck of the esophagus, at the neck of the stomach, at the very bottom end of the esophagus, that can have some detrimental effect and can cause dysphagia. Iatrogenic diagnoses, so these are basically side effects of radiation therapy, chemotherapy, Parkinsonian agents. So these are medications that are taken to treat Parkinson's disease, for example, can lead to dysphagia. Post-surgical procedures, anything that involves, working on the head and neck region or the oral cavity, for example, if it's to remove a tumor or to remove a lump or a cyst, anything that will, damage one of the 5 cranial nerves that are important for swallowing, can impact, again, the swallowing process and can cause dysphagia. Medications is a very big one. This goes unnoticed sometimes, and this is something you need to look into. You hold a chart, you have a patient, you need to ask them about what kind of medications do they take, because it's very important to know what they are on. So antidepressants, diuretics, antipsychotic medications, these medications cause what's called xerostomia, which is dryness of the mouth, okay? Now, dryness of the mouth can be a problem, and it can cause a swallowing problem, because when there's dryness of the mouth, there's no saliva being produced, then you are unable to chew and successfully break down the food in order to swallow it safely. Okay, so having a dry mouth is it's a significant side effect that we need to look into. Then we have intubation or tracheostomy, and I put post-extubation COVID-19. So this is the new hot topic now. Because of lots of patients now going onto mechanical ventilation because of the COVID-19 pandemic. التنفس الاصطناعي or the intubation itself يسبب مشاكل عديدة، ومنها مشاكل في الأحبال الصوتية وغيرها أن تكون مشاكل في البلع نفسها. Once this tube is extubated or taken out, so post-extubation, meaning once, okay, they are off the ventilation, they remove them off these machines, they take out the tube, then we notice, or that it's been noticed that a lot of these patients may have dysphagia and swallowing problems. And so we will see, because there is a rise in the number of COVID-19 cases, people being on ventilation in the ICU, we will see a rise in the number of dysphagia cases. And this is why it is crucial for us to be working in the hospitals, especially in the ICU units and in the acute rehabilitation wards. Okay. So other diagnoses would be any kind of severe respiratory compromise, so chronic obstructive pulmonary disease, for example, COPD, and some psychogenic conditions. Okay, this is a table of the medications that can have some side effect. Okay, you may look at some of these and not understand what they are. It's okay as long as you discuss this with the pharmacist or the prescribing physician. But what my take-home note is there are medications, lots of medications out there that are given to the patients that can cause some kind of a problem that leads to dysphagia. Here, this one, for example, antidepressants and antipsychotics can cause things like confusion as well, you know. So the cognitive aspect there is also impacted, as well as dry mouth. Poor coordination, for example, in some of the anxiolytics, a change in taste in anti-inflammatory agents. Even the diabetes medications can have an impact. So don't overlook anything. That's my take home. So the consequences of dysphagia, early detection is key. The early detection of dysphagia is very, very important. The sooner you catch it, the better the chances are you will avoid a host of problems, not just disease, but you can also prevent mortality, which is death. Medical consequences, things like malnutrition, dehydration, aspiration, and aspiration pneumonia. Malnutrition will make sense because these individuals will limit what they eat. So after a while, what you see is the patient will notice that he has problems, for example, or difficulty eating bread, for example. That patient will stop eating bread because it is uncomfortable, it gets stuck in the throat. So he stays away from, you know, eating carbohydrates, which is an essential nutrient for everybody. And so malnutrition, you'll find some fluctuations in the nutrients. So working with dietitians is very important as well to gain an understanding of what's happening, what is deficient in this patient, and how can we replenish this nutrient that's being deficient in a safe way. Dehydration, of course, because a lot of these patients will have poor oral intake of liquids, and it's inadequate. You know, they drink, they'll start choking and coughing, so they don't drink enough, they avoid drinking. And then aspiration of any kind of food or fluid into the airway will lead to something called aspiration pneumonia. So aspiration is when the food or the fluid that is being ingested and taken in goes into the airway, into the trachea and the lungs, rather than down the esophagus. So it's basically going down the wrong way. We find 25 to 30% of patients with dysphagia are silent aspirators. What does that mean? Silent aspirators are a huge red flag. So these are individuals that will have a problem with swallowing. The food or the liquid will go down into the airway. But typically, if you or I drink something and we choke, the body's reaction is to what? Immediately cough to push out whatever went down into the airway, okay? With these individuals, they lack this. Okay, so silent aspirators, meaning these people will aspirate, the food or liquid will go down into the airway, but there's no reaction by the body to this. There is no coughing, no choking, no vomiting, no gagging, no kind of reaction for them. And they don't feel that they are aspirating. And these silent aspirators are typically seen in probably more so in the population that has neurodegenerative diseases, okay? Or a stroke, for example. So they lack that sensation. Silent aspiration has a high risk for developing aspiration pneumonia. So these individuals are more likely to have pneumonia and more likely to die from the pneumonia as well. And the elderly with dysphagia, those who have silent aspiration have a higher mortality rate. So there's a correlation there. The chances are much higher for mortality if they silently aspirate. And we need to catch that with proper assessment. Then we move on to, of course, the social aspect of eating. So Eating is a big thing. We eat and socialize over meals, especially in the Middle Eastern countries. Food is a big part of our lives. And so once these individuals feel like they can't really, hold down their fluids or food, they regurgitate or they choke and they cough, they feel a sense of embarrassment. And so not only do they change their routines and what they eat and their food choices, they lose pleasure in eating. They hate eating altogether, and they don't want to do that in front of other people as well. So they limit their social gatherings, and that ultimately impacts their quality of life. This is just a quick sort of, it looks like a cycle if you want to look at it that way. I look at it as a circle. So how dysphagia can impact aspiration, pneumonia, or causes aspiration pneumonia, impact nutrition and hydration. And of course, if we have malnutrition and dehydration, then we will have poor wound healing and poor recovery. Okay, thank you, Manar. Sorry. Okay, so you'll have things like poor wound healing, increased risk of breakdown of muscles, of degeneration of muscle, decreased cognitive and functional status. If you are malnourished and dehydrated, then you will not the body will not function optimally. And so that will in turn affect or impact the ability to swallow and feed as well. Okay, so anatomy and physiology of swallowing. First things first, deglutition is a word that you will come across in textbooks, and you'll come across this a lot. Deglutition basically means swallowing. Okay, so this is another fancy word that means swallowing. So it's the act of swallowing through which a food or liquid bolus. Another word to watch out for here is bolus. Bolus means any kind of food or liquid that you ingest and take into. So anything that you eat basically or drink is considered or named a bolus. So it's just a fancy scientific name for anything that you eat or drink. So deglutition is the act of swallowing through which a food bolus is transported from the mouth through the pharynx and the esophagus into the stomach. Okay, long pathway through the alimentary tract. It's an innate ability that we develop as humans, even as fetuses. Even in the womb, the fetus is able to swallow. And I don't know if you've seen, but there are some videos of ultrasounds of baby infants that actually we can notice that they are swallowing the amniotic fluid. So swallowing is actually a very, very primitive kind of act that we learn very, very early on. And it's necessary, of course, to maintain hydration and nutrition. It's a very fast process. It's quick, it's efficient, it's brisk. And so this is a typical normal swallow. It's supposed to be fast. On average, we swallow about 580 times a day. That's a lot. And it could be food or saliva. And the swallow reflex is mediated in the medulla part of the brain. Okay, so swallowing is mediated basically within the central nervous and peripheral nervous system, and it has motor and sensory components to it. Sensory being the taste and the texture and temperature of anything that you are ingesting. So we are able to distinguish that, as well as the motor act of swallowing. I won't get into that. This is another lecture on anatomy, so do bear with me. Okay, normal swallowing performance depends on the rapid transfer of the bolus meaning the food or the liquid from the oral cavity to the stomach. We need for this act to be very fast, efficient, and safe at the same time, okay? And we take that for granted, I think. You know, if I pick up the bottle of water and I drink, I don't, without thinking, you know, it'll take me probably just 2 seconds to ingest and swallow safely that sip of water. And that's how it should be normally. Okay, so it takes approximately 5 seconds, you know, from start to end to drink a bolus. Efficient movement depends on the strength of the neuromuscular contraction exerted on the bolus, gravity, and the bolus consistency and volume. So how fast can I eat or drink something? It depends on lots of things. How effective are my muscles when they contract and push the bolus and exert pressure on it? The consistency of that bolus. If it's a liquid, it's going to go through very quickly because it's very light. Versus if it's a solid that is very consistent, cohesive, thick, for example, like bread, which needs chewing first, cutting down, breaking down, and then swallowing. That'll be a little bit slower. And gravity as well plays a role. Okay, am I going too fast? Menar, am I going too fast? Because I tend to do that. Yeah. Okay, good. Thank you, Noor. All right. Okay. So swallowing or deglutition continued. So efficient bolus movement is achieved when coordination of the neuromuscular contractions and relaxations create positive and negative pressure. I will explain that with a diagram in a bit, but what this means is that there is positive pressure acting on the bolus and there is negative pressure acting behind the bolus. This negative and positive pressure really determines how efficiently and quickly we can move the bolus from the mouth down into the stomach. And it's important that we have efficient and good positive and negative pressures. This becomes something that a patient will lack, of course, with weakness in the muscles, whether if it's in the head and neck, or poor neurological control. Okay, and typically we would measure that with manometry in the lab. So lower in the swallowing chain, we have the esophagus. So it's just because it is sort of vertical, it goes down. It is under negative pressure because of its location. Okay, so the negative pressure would be towards, if you think about the esophagus, that's where it will be. Cranial nerves that are important in swallowing are the trigeminal, facial, glossopharyngeal, vagus, and the hypoglossal. Again, this is a bit of anatomy. I don't have time to go through anatomy, really. My aim here is to just, if you can leave just at least understanding the phases of swallowing and the process itself with dysphagia and linking dysphagia to that, I'll be very happy. So phases of the normal swallowing, typically most textbooks will describe it as 4 phases. The oral prep, oral phase, pharyngeal, esophageal. Sometimes you'll pick up a textbook and it has 3 phases, oral phase, pharyngeal, or esophageal phase. I'm going to describe it as 4 phases. So the oral prep phase is voluntary, okay? Voluntary meaning I have control over it. I think about it and I have control over it. There's sensory recognition of the food here. So we see visually for example, spoon of soup, it's coming towards my mouth. There's recognition, sensory recognition, visual recognition. I can smell it. It touches my lips. I can feel if it's hot or not. And its placement in the mouth. This is typically where the oral prep phase is at. And then it will enter into the mouth and there is manipulation of the actual bolus or the food that I've taken in, okay? Again, the movement here depends on or how much control I do or have, or manipulation, sorry, not control. How much manipulation I need to do depends on what it is I'm eating. So if it's a liquid, it's just a quick sip and I swallow. But if it's a solid, then I'm going to be masticating or chewing and breaking it down with the saliva, of course, to push it down easier. Also, the purpose of this phase is to prepare the bolus for swallowing. It ends really when the bolus reaches the dorsum part or the top part of the tongue. Okay, so here there's a bit of chewing and it's sort of preparing the bolus to sort of continue chewing and push it back. Mastication, I've defined here, occurs to grind the bolus into manageable texture. So mastication basically means chewing. Okay, so breaking it down and chewing. Okay, Al-Hanouf Al-Askar, when do we judge if it's delayed oral transit time? I will get to that later, okay? I'm just talking about normal swallowing now. Okay, so keep in mind, we are now talking about normal swallowing. I'll try to check every now and then for the comments and the questions. That's a good question though. But typically now we're talking about normal swallow. Okay, so we know it's brisk, it's fast. A delay is kind of is significant. You can tell it will take longer than usual to, for example, manipulate something as easy as a liquid. But the active mastication here requires the lips, the tongue, the teeth, the mandible, the cheeks, lots of oral structures. And it ends when the bolus is gathered on the top part of the tongue, the dorsum part. And it really varies how long this phase is, depending on what it is that I've ingested. If it's a liquid, it's going to be faster. It will be a short phase versus if it's a solid. Respiration here is normal. So while I am eating, I am inhaling and exhaling normally. The active respiration is normal and it's through the nose. Oral phase, again, is also voluntary, under voluntary control. Now, this phase is important as well. These two really, they kind of mesh together, the oral prep and the oral phase. With the oral phase, I've noted, but it's also in the oral prep phase. Intact dentition, meaning good set of teeth. And typically we will say that because the kind of patients that come to us are the elderly. And so if they have dentures that are loose or dentures that are not fitting properly or they're too tight or they're causing friction and inflammation inside, then that is not a good fitted denture. If they have missing teeth, for example, then again, that will impact the oral phase. So salivary control as well. If there's poor salivary gland function, if they are taking any form of medications, the oral phase and the oral prep phase will be impacted. If there's any kind of surgery that's caused weakness in the muscles, if they've had a neurologic disorder such as a stroke and they've caused weakness in the tongue, there's poor movement of the tongue, the elevation and the movement side to side of the tongue, or pushing the bolus up and down, then again the oral phase will be impacted as well as the oral prep phase. Once the bolus is prepared, the tongue tip is elevated to occlude the oral part, the anterior part of the oral cavity, to sort of push it back. It's sort of like a wave kind of movement. So it'll close to the top, the front, the anterior part, the tip of the tongue, and it will move and push back the bolus to trigger the next phase, which is the pharyngeal phase. So the bolus is held up against the hard palate to help push it back, and it is then pushed back into the oropharynx. The back portion of the tongue delivers the bolus into the pharynx. Okay, so here it's being pushed. The soft palate you'll see is still sort of open, not completely closed yet. Epiglottis here is open, the airway is open. We are here, it's beginning or triggering the pharyngeal phase of the swallow. Okay, we have retraction, meaning the pushing back of the tongue that's happening to push the bolus back into the pharyngeal wall. And so the tongue base applies that positive pressure. Okay, so the tongue is the one that forces the bolus through, meaning it is what's causing that positive pressure. And then as a result, it will close the soft palate. In this phase, the soft palate moves up eventually as it is triggering the pharyngeal phase, and the tongue will drop down and back. And so at the same time, you'll also notice the movement of the hyoid bone by the mylohyoid and the geniohyoid muscles. It'll pull the hyoid bone, just because what we need to happen here is the epiglottis needs to invert and close over the larynx itself. It needs to close off the airway. So the elevation of the hyoid may actually be initiated as the bolus is positioned in the swallow prep phase. Okay. So the foreign bolus, when it's done to be swallowed, is pushed to the dorsum of the tongue and then pushed firmly back. It hits the tonsillar pillars or the fascial arches in the back of the throat, and that triggers the pharyngeal phase. So the Fascial arches will be there, just about here. We can't really see them on this diagram. Duration of this phase is about 1 to 1.5 seconds. Respiration is still normal. We still breathe in and out through the nose. Now, the reason I say duration and respiration is because this is normal swallowing. Anything out of the ordinary that doesn't happen within this picture, then we will consider dysphagia. If we are, for example, holding our breath here at this stage, that could be a problem. Or if we are, inhaling and there is respiration happening while it is in the pharyngeal phase, that is a problem because we can aspirate on the bolus. So to describe this is basically just to show you what is normal. The pharyngeal phase is involuntary. Okay, so this is the beginning of the involuntary reflex of swallowing. So here we see the soft palate and the velum closing all the way up to the back of the pharyngeal wall. Okay, the tongue is sort of going back into its original position, but the base of the tongue is probably still exerting positive pressure on the tail of the bolus. This is the head of the bolus. And then we have the epiglottis, nicely tucked all the way down and in, closing off the airway. So when does this phase start? It's when the food actually hits the back of the throat. This is where the tonsillar pillars are, or where the fascial arches are. And that triggers the swallow immediately. So this stage of the swallow is reflexive, it's involuntary, it occurs very quickly. The pharyngeal wall and the back of the tongue move together, they squeeze together to push that bolus down and away from the airway. The airway then reopens towards the end of this phase, and the hyoid bone returns to normal, dropping down the larynx into its original position so that it can open up and we can start that process of respiration again. So if we look here, we have important sphincters, which are basically they are sort of rings of muscles that act as a valve. If you think of a valve, and I don't know if there are any guys out there, if you think of a valve in a hose or any kind of a tube, the valve, what it does is it has to sort of make something go in one direction. So it closes off immediately to stop the redirection of a fluid or anything. The UES, or the upper esophageal sphincter, and the lower esophageal sphincter are very important to maintain that unidirectional or one direction flow of the bolus, whether it's food or liquid. So as soon as the bolus moves down, this will, of course, when it's here at the pharyngeal stage, this will be relaxed. Okay, so the upper esophageal sphincter, the cricopharyngeal muscles, they will all relax. These are both here. They will relax to open up and to allow the bolus to go through. Once the bolus goes through, normally this will contract again and close so that the bolus is pushed all the way down the pharynx, down the esophagus, and through the lower esophageal sphincter. So we not only have one valve, we have two valves at the top and at the bottom. The lower esophageal sphincter is another valve, just to be sure that no acidic contents go up from the stomach. The stomach has lots of acidic material in it, and we don't want it to go all the way up to the throat. And so this makes sure that everything that goes and enters into the stomach stays in the stomach. So this relaxes, opens, bolus flows through, goes all the way down. This relaxes and opens. This will contract to keep it going down. And then once the lower esophageal sphincter opens up, it'll go down and through into the stomach, and then it'll close again. The pharyngeal phase of the swallowing is the shortest, but it's the most complex phase. Okay, it involves a lot of coordination of the muscles, neurological, neuromuscular coordination as well, and control. And so it is involuntary, but it's also very complex in the way it operates. It is also, so it is the shortest, meaning it's approximately about 1 second for things to go through the pharynx. I've kind of gone ahead and talked about the esophageal phase, but that's okay. Now, during the pharyngeal phase, we have the apneic moment, which is when breathing is halted and stopped momentarily. And that's very important because that's a protective mechanism. So if we look here, okay, the epiglottis is closed completely over the airway. That means there is no inhalation or exhalation happening at the stage. But because it's such a short phase, it's only 1 second, that's okay. And so that is what we call the apneic moment. Okay, and this happens just because there's high risk of food entering into the airway. So we need that nice closure as a protective mechanism. So we have protective mechanisms, if you've noticed. We have the cessation of active respiration. We have the apneic moment. So we have to stop breathing. We have the soft palate elevating to stop the food from going into the nasal cavity and causing regurgitation, nasal regurgitation. We have the larynx and the hyoid as well, moving forward and elevating to close the airway, and the epiglottis as well, forming a cover. We also have the vocal cords closing. So it's not enough that the epiglottis closes, but we also have the vocal cords closing in together to stop any food or liquid, just in case, from going through. And if all fails and somehow something does enter, and that does happen sometimes when we choke, there's a reflexive cough that will push any food or liquid that is entered out of the airway. Okay, I'm just gonna check here. ممكن استعمل العربية. اوكي آسفة جدا، لكن العربي عندي يعني وايد مكسر، فأشياء مهمة. I don't know how to، يعني honestly ما لقيته إلا أصعب موضوع إني أشرحه في العربي. Okay. Let's see. Apneic period, if that's throwing you off, apneic moment معناته فترة زمنية قصيرة جدا، بتكون تقريبا ثانية هي يوقف فيها التنفس completely يوقف، لأن إذا بطلنا الأبيغلوتس مثلا أو تبطل للتنفس رح يدخل لمجرى الهواء طبعا الأكل أو الماء. ف this is a protective mechanism. هذا شيء يساعد على أن يحافظ على الايرواي او الجهاز التنفسي نفسه، على اساس ما تدخل اي شيء، ما يدخل يعني اكل او ماء، لانه راح يسبب مثل ما قلنا aspiration pneumonia اللي هو الالتهاب الصدري، او infection في الجهاز التنفسي او الرئه نفسها. This is as much as I can do. Anyway, okay, aspiration. Aspiration and penetration are very important. Two things can happen once food enters the airway. Okay, عندنا شغلتين ممكن تصير. في إذا دخل الأكل أو الليكويد أو الماء فوق الأحبال الصوتية just in the beginning هني تحت الأبيغلوتس بالضبط, we call that penetration. Okay, it's above the level of the vocal cords. It's above فوق الأحبال الصوتية راح يكون, and it doesn't really go through. When do we call it aspiration? It is aspiration when it goes under the level of the vocal cords. Okay, so when food or liquid enters the airway below the level of the vocal cords into the trachea, into the airway, then this is what we call aspiration. Okay, so penetration, we can sort of, you can see penetration sometime happening, but then the patient will have a good cough and then the vocal cords will push out whatever they have aspirated in. And we just call that penetration. But if it keeps going down through the level of the vocal cords, then we call that aspiration. And this is important to know, because when you come to the assessment of dysphagia and sort of classifying it, you need to look at, okay, what is happening? Is there aspiration or is it just penetration that is on the image that you are looking at? All right. So the relationship between swallowing and respiration, it's reciprocal. It's very important. They kind of work together, but not really together. So, but they have to have an understanding or relationship. Basically, what this means is they have to be in synchrony where we stop breathing when we are ingesting and swallowing, and then it has to know when it is acceptable to, have respiration happening again. And so respiration needs to stop during that pharyngeal phase of the swallowing, specifically, where it's a danger zone, I guess you can say. So swallowing is an airway protective reflex because of the interchange of the functions that happen. We have one track basically, and then it splits into two. And so we need this coordination. The final phase is the esophageal phase. Again, it's involuntary, and we have something called peristalsis. So esophageal phase of the swallow begins when the bolus reaches the cricopharyngeus muscle and the upper esophageal sphincter, where I showed you. Okay, so where those valves are, this is where the esophageal phase will start. Once it opens and the bolus goes through, we have the beginning of the esophageal phase. And it will end at the lower end of the esophagus, where the LES is at, the lower esophageal sphincter. Once it passes through there, the head of the bolus, then we have the end of the esophageal phase. The purpose of the esophageal phase of swallowing is to transfer basically from pharynx to stomach. That's it. Peristalsis, when I say peristalsis, is that rhythmic contraction. Okay, تقلصات في جدار الاسophagus نفسها، العضلات اللي فيها نوعين من العضلات, something that is longitudinal and something that is circular. Okay, and they have sort of different actions, and they work together to push the food down. Very effective and very efficient. It's involuntary, so it's not something that we think about, and it's a rhythmic kind of action. So it happens in a rhythm to push the food very quickly and efficiently down into the stomach. The bolus is then propelled through the esophagus by an involuntary wave of contraction, okay, which we call peristalsis. So it moves all the way down, it's being pushed down. UES then closes, LES will open, bolus will go through to the stomach, LES will close again, okay? This phase can happen, it can take anywhere from 8 to 10 seconds. It is the longest phase, but I have to warn you that it can be much slower, especially if you are looking at the radiography of, or the swallowing phases of an elderly patient, okay? So it'll change. The timings are, there for reference, but again, you need to know if it's a delay or if it's a disorder, and that comes with practice, okay? But anywhere in this range, this is normal. This is considered normal. And with age, that will increase in duration. There is something called presbyphagia, which is a difficulty in swallowing, and that is but specifically related to aging. It's not related to disease or neurogenic changes. It's something that happens naturally as we grow older because of the weakness in the muscles. So we need to be careful, when we diagnose, is it presbyphagia or is it dysphagia? So the duration and characteristics of each of these phases really depends on, as I mentioned, the type and volume of the bolus. How much am I ingesting? If I take a big bite, then I'm gonna chew longer. It's gonna take a little bit longer. So you need to gauge that. Is the bolus that I have, if it's a small piece of, for example, biscuit, and I'm taking, and the patient, for example, is taking more than 5 seconds to chew it, and it's a small piece of biscuit, then we know that's a delay. There is something wrong. There is poor control in the oral cavity, okay? So it depends. How much are they eating, ingesting, and how long is it taking? So what's the volume and what's the type? If it's a liquid, then it's a quick and brisk movement. But if it's a solid, okay, I understand it's gonna take some mastication and chewing and control, but how much volume is in that bolus for it to go through? Sometimes what happens is they will swallow, and then it's followed by a secondary swallow for the remaining bolus. If it's a big bolus, that is okay. If it's a small bolus, and you see that happen with neurogenic disorders like Parkinson's, then you'll see multiple swallows of something that's very small. That is disordered and that is abnormal. Okay, so keep in mind, type and volume of bolus. How long is it taking? Does it make sense to you that it is taking, you know, more than 5 seconds for somebody to chew a small piece of biscuit? And again, we also, what affects these phases is the voluntary control exerted over the bolus. So how much muscular control does the patient have, and how well is the coordination that's happening? So these are the 4 phases of swallowing, and you can see where the bolus is at in each stage. Okay, here it's gone completely through into the esophagus. So when we classify dysphagia, we will classify it as 2 types: oropharyngeal, involving the oral cavity or the pharyngeal region, or esophageal kind of dysphagia. This would be an esophageal dysphagia, or this could potentially lead to esophageal dysphagia because there's a cancerous lump or tumor at the head of the stomach, within the esophagus itself. So this could lead to esophageal cancer, esophageal dysphagia, sorry. So when we have disorders now within each phase, what do we notice? Okay, in the oral prep phase, think about the anatomy. Okay, so when you think about the anatomy, okay, think, for example, stroke, weakness in the muscle, weakness in the jaw and the mandible, poor dentition, think of things like that, the movement of the tongue itself. So you will find problems of chewing the food efficiently and well, reduced range of movement. Typically what we do is we do a grinding kind of motion when we eat and ingest something. When we masticate, there's that grinding motion. Sometimes what you notice with some patients is there's a chopping kind of motion, which is not really effective and doesn't really break down the bolus very well. So what's happening in the dentition, with the teeth, with the jaw, with the upper and lower jaw? The mandible isn't moving well, if it isn't moving side to side efficiently. Buccal tension, so tension within the muscles of the cheeks. Poor alignment of the mandible and maxilla. If there is poor alignment of the top and the lower teeth, if there's an underbite or an overbite. Difficulty forming or holding the bolus within the mouth. Sometimes what you will see is anterior spillage. So spillage of the bolus, drooling of the food or the liquid that is ingested. Then we know there's poor control, poor muscular control within the lips, muscles of the lips, within the buccal, the tension within the buccal cavity itself, and the tongue. The tongue is unable to control or hold that bolus. And if there's aspiration before the swallow due to, again, weak lip closure, lack of bolus control. So what happens is when they drink the liquid, if we look at the diagram, it'll go immediately to the back rather than being held up against the hard palate and then being pushed slowly down in coordination with everything else. One other thing I wanted to mention here is rocking tongue movement, and we see that sometimes with neurogenic disorders. So not only do you notice that they swallow multiple times, it's a small amount of bolus, but you will also notice that sometimes the tongue itself will have that rocking kind of motion. We don't usually see that in a normal swallow. So typically the tongue will have like a wave-like movement from front to the back. But with these individuals, it's sort of like the tongue is trying to figure out what to do with the bolus. And it keeps the bolus on the top and it moves front and back. That's a rocking kind of movement. Typically, we see that as well in Parkinson's. So with the oral phase, we'll see the same thing, weak tongue movement. The tongue cannot move the bolus around or contain it within or on top of the tongue itself. So the range of movement of the tongue is weak. Then we also see something called food residue. So another thing that you need to do when you're assessing, and we'll talk about that in the assessment of dysphagia. Sometimes when you are observing and assessing, you'll give them a bolus, like a food, like a custard or a yogurt, and they eat. Then you ask them to open their mouth. Once they open their mouth, you'll see food pocketing on the sides, okay, within the tongue, within the cheek region, okay? So in the sulci on the sides. So food residue is not supposed to be there. When we swallow anything, no matter what the consistency is, it all goes down, and usually within one swallow, maybe two, depending on the age. But typically, even if they have 2 or 3 swallows, sometimes these patients will still have food within the oral cavity itself. That's due to not them not being aware of food being there, and they need that prompt to sort of initiate a second swallow. So that's typically seen in stroke patients and the elderly as well. Disorders of the pharyngeal phase, typically here we will see difficulties in pushing the bolus to the pharynx and into the PES, delayed or absent swallow reflex. So that initiation of the swallow reflex is delayed. You see the food slip all the way to the back. And it'll take some time for the swallow to be triggered. So it'll go down, down, down. You'll see it reach the level of the entrance of the airway and the epiglottis is still open. And it's a very scary thing to see. And so that can also happen. Nasal regurgitation, if there's velar weakness, velar insufficiency, so the soft palate is not really closing very well, and there's nasal regurgitation, so the food basically just comes out through the nose. Then we have weakness there in the soft palate as well. And food coating the pharyngeal walls. What I want to show you in this next diagram is this. So the food coating on the pharyngeal wall. When we swallow, so if you appreciate this diagram, these are the teeth. These are probably just some fillings within a teeth. That's another molar maybe. That's the hard palate right there. And the food is sort of dripping all the way to the back of the tongue, but it's collecting here, and this is the valleculae, which is at the top of the the epiglottis, sorry, and then at the piriform sinus, just below, near the cricoid cartilage. This is not supposed to be there. This is supposed to be cleared through with 1 or 2 swallows maximum. Okay, so you don't want to see that in an image. So also with the pharyngeal phase, you can have reduced peristalsis, inadequate closure of the airway. Again, if the epiglottis doesn't close very well, you have aspiration. You have reduced laryngeal movement. So we understand now the laryngeal movement is very important. The larynx has to elevate for the epiglottis to close. And so if it is a reduced movement, then there's incomplete closure of the epiglottis or the arytenoids as well, because they overlap onto each other. And so that it could be a problem. We can also notice cricopharyngeal dysfunction or a problem with the cricopharyngeal muscle. If we have a problem there, then we see something like this. It's called Zenker's diverticulum, which is like a pouch or a pocket that forms in the back of the throat, basically. Okay, there's a weakness in the actual muscle, the cricopharyngeal muscle, and it opens up. And what happens here is when you swallow, sure, this will close, but the food will collect here rather than go down the esophagus. And that can still cause regurgitation. Once this opens up again, the food will go back up. What happens in this case is people notice that they have a feeling that the sensation of, they call it globus sensation. So like food is getting stuck within the throat. And then they feel the food is coming back up and it's not digested food, so it's not, sorry for this, but it's not vomit. So it is undigested food and it just goes back up again. Okay, and that's because it hasn't really reached the stomach to go back up. It has just reached into this pouch and then it moves back up into the oral cavity. So that is something else to watch out for. If you do an MBS swallow study, it can look something like this. So the pouch is very clear here. There's a bit of constriction happening at the esophagus as well. The esophageal phase difficulty here would be mainly with the peristalsis and the contractions. You can also have diverticulum happening within the esophagus, and you can have something called a fistula, like a hole or an opening that forms within the actual esophagus itself. So it'll open up into the airway, and that's very dangerous as well. That fistula needs to be surgically repaired and fixed. But I think one of the more common problems of the esophageal phase is the growth of a tumor or cancer within the esophagus. It's very prone to cancerous growths, that region. And so you have esophageal cancer, mainly being the cause here of dysphagia. Okay, I have this nice I wanted to show you a couple of videos about how, all right. This is a nice website that I would highly recommend that you go to. It's called Radiology Assistant. It has a bunch of images that describe different things. This is a nice head and neck view that looks at, or a fluoroscopy that's done to assess swallowing. This is, just to keep in mind, is a normal swallow. The first image that we come to is here. Okay, you can't see the front of the face. Just go like that. You can't see the front portion. All right. But what you can see is the bolus. This is the head of the bolus, okay? And the beginning of the bolus. The bolus is in the oral cavity. I don't know if there's any anterior spillage or drooling happening, so that would be anterior spillage. So if the patient is losing the bolus to the front, through the mouth, through the lips, but we will assume there's nothing there. But otherwise is above the actual tongue. So it's held nicely, okay? Then we move on to image 2. We see more movement. Notice this is the hyoid bone. This is the epiglottis. The airway is open. This is the oropharynx. This is the airway. This is the head of the bolus, okay? And just watch how it moves nicely together. It'll move together in sort of like a coordination. Okay. Soft palate is still open at this stage. Okay, it is. Just keep an eye on this and the epiglottis. See how they move eventually. Now, this has moved slightly, but we have closure of the soft palate. I'll just go back one more time. And again, and you see posterior spillage here. Okay, so this is collecting at the valleculae. Okay, so far that's fine, okay, because it hasn't really slipped into the airway. And some people do this normally, and so I still will not grade this as anything abnormal. Then we have now notice the hyoid bone has shifted to the front, okay? Notice again, hyoid bone moved up. And because it has moved, the mylohyoid and the geniohyoid muscles will pull the larynx up. So it has moved up, it has pulled up the larynx, and with that, it has closed the epiglottis and the arytenoids onto each other. So now there is a trace amount here behind the base of the tongue. There is liquid. The bolus is falling down through the esophagus safely. It is probably here at the cricopharyngeal muscle is probably here. The upper esophageal sphincter is around here as well. So it is entering. So that's the head of the bolus, tail of the bolus, positive pressure being applied, and it is still being applied all the way down for it to go through. And notice there's still closure. Otherwise, you would see this slipping in and going into the level of the vocal cords. Okay, so at the stage here, the larynx is still closed. The cricopharyngeal muscle is open and relaxed to allow the bolus to go through. Okay. It'll probably start closing now, the cricopharyngeal muscle. Now it has completely gone through to the esophagus. Airway is clear. No penetration, no aspiration. Okay, and then the epiglottis here is open again. The larynx is open. There is coating at the valleculae and at the piriform sinuses. Okay, we watch that. We might ask them to do another swallow, and that might clear again. But otherwise, that looks normal. Nothing happened here. Okay, so this is a normal view. If we go to something else that looks abnormal, it is clearly going to appear as abnormal. Okay. Okay, this is probably a better view.
Here's the jaw.
Is it okay now? Perfect now. Okay. You won't see as well, but we're going to have to work with this.
1/2 teaspoon thin liquid.
Okay, this is still a normal swallow.
Teaspoon thin liquid. Okay, said thin liquid.
Thin liquid. The actual, so they have to report what they are doing, because when you come to sort of do the charting and analyze these videos, once they are recorded, you have to understand what the patient is eating or drinking, because you can't tell otherwise. But you can tell it's fast, so you know it's a liquid. But there are different consistencies, so this is what they're working with now. So a little bit of coating that happens at the valleculae, but then it's cleared.
1/2 teaspoon thick liquid. 1 teaspoon thick liquid.
Yeah. I can't maximize the screen.
1/2 teaspoon paste.
So this is something thicker. It's a paste, more like a solid. It's still going through okay.
1 teaspoon paste.
So here, notice the chewing and the grinding. That's a solid. There's some residue here. It's collecting at the valleculae, but that's fine so far. Okay. Okay, now this is an abnormal swallow, and this is a very, very clear one. Sometimes they're very difficult to catch, but this is just a very clear one. Easier for you to see. Okay, notice how it's gone to the airway completely. There was very, very minimal movement of the epiglottis. So we had some deflected here into the esophagus, but a lot of it just went right through into the airway, and it's going all the way down into the lungs.
Swallow again. Swallow again. Swallow. Yes.
So again here. No voluntary cough either. So typically what would happen to somebody that has this, a normal person, normally we would cough, we would choke, we would turn red. But this person is just, the fluid is just going through, and it's just going right into the airway with absolutely no reaction.
Yeah.
Yes, exactly. That is silent aspiration.
Yeah. Swallow again. Swallow. Okay.
All right, here we go. So that was normal and abnormal. This I will skip just because of time. Okay, so we are reaching the end of my lecture, I promise. I've talked enough, I think. Remember that dysphagia is not a primary medical diagnosis. It's secondary. It will happen, it's a co-occurrence or a symptom of some other deficit that's happening, okay? And so is silent aspiration a problem in sensation? I'm not sure I understand that well, what you mean. Just type that question again, and I'll get back to you. Oops. Okay, so it's a symptom of an underlying disease, we said. There could be a diagnosis of a stroke or TBI or any kind of neurogenic disease. And then secondary to that, we get the dysphagia. In older age, when we just see dysphagia happening, naturally occurring, that's called presbyphagia. That is something completely different. Okay, so in aging, I know that elderly, you're gonna say, well, they have problems swallowing, yes. But is it significant enough to cause a problem or cause malnutrition or death or aspiration, pneumonia? Probably not. I mean, they could probably be okay with the presbyphagia. It's hard to determine, but a pure dysphagia will be a co-occurrence with some other kind of disease. How do we get information about the signs and symptoms? So we typically, as speech pathologists, will observe. We will observe them during meal times. We will observe them taking their medications, bedside exam. This is where the clinical exam is very important. And this is something we would talk about in the second part of my lecture, because there's so much to talk about when it comes to the assessment and management. So what we observe, what we see from the, watching the patients, and the symptoms and complaints of what the patient reports to us. Do not underestimate the reporting of a patient, but you have to be in tune. So you really have to know what it is that signals a red flag. Typically what these patients will come to you saying, I used to eat this, but I stopped because, I noticed that it's too difficult for me to eat. Something as subtle as that can signal a dysphagia. Sometimes the patient will come and say, well, I have this like lump feeling in my throat, or I choke every time, I sip on my tea. Or I stopped eating this because every time I eat it, it causes me to cough. So it's, again, the complaints of what the patient is reporting, what the caregiver is reporting as well. So things to watch out for are coughing, choking after a meal or during a meal, food sticking, so they feel like something is stuck in the throat. There's something called a globus sensation, which is like a lump. They feel like there's constantly a lump in the throat. There's that wet voice that they have immediately after they eat something. So typically what we would do with this, and what we notice is after مثلا they take a sip of water and you ask them to phonate, or so to say, for example, you will hear the vocal cords sounding wet. And so that would indicate possible dysphagia or aspiration, sorry. Absent gag reflex. So when you are doing the oromotor exam and you poke in to sort of trigger that gag reflex, which is important in an oromotor exam, then you don't notice any gagging. اللي هي شعور التقيؤ أو النبير يرجع once you go in with the tongue depressor gently to sort of test the gag reflex. Food avoidance, so they will say, I stopped eating this and that and steak and bread, for example. That because you'll have to know why. Is it just a food preference, or is it difficulty in eating? Pocketing of food in the mouth. You can ask, for example, the caregiver that is taking care of the patient, what do you notice? Do you notice that, they finish their food, the oral cavity, do you check their mouth? They might say, well, sometimes I'll come back, 20 minutes later and I'll find some food from lunch still in the mouth, and within the cheeks or in the sulci. And that is unusual. So that is pocketing of the food in the cheeks. So typically when we assess them in the clinic or in, within the hospital setting, we like to go and see them during meal times. We see how long it takes for them to eat. Is it quick, or is it a lengthy meal time? Does it take them, more than an hour to finish a small meal? You tell them to open their mouth. You check the oral cavity, any food residue or pooling of food within the mouth. any regurgitation happening, any coughing, any choking. Are they reporting adenophagia, which is pain when they are swallowing? Is there any anterior spillage? Is there any drooling that's happening from the lips, from the mouth, the corners of the mouth while they are eating, or just naturally? That means they have poor oral control of their saliva. Is there weight loss? And is there any nutritional deficiencies? So that is either reported or is something that you will pick up from the actual medical records of the patient. This is just a quick sort of symptom and sign table that summarizes things. Typically, a lot of these things we would see on a radiographic study. And so an MBS would be a good way to really pinpoint some of these problems. But we usually, when we talk about the assessment, we typically will start with a clinical exam first before we do anything. So subjective complaints made by the patient may be useful in guiding the exam, but it should be confirmed with an objective data. So you take the complaints into consideration, but that is not what you go by when you are planning anything with the patient. You have to assess, you have to screen, and then you have to assess either with an instrumental exam or whatever it is that you decide to do. Our role as speech pathologists has expanded over the years. And so we have now taken more of a role now with the feeding issues and the swallowing issues of patients. Typically, I think here patients are assessed and looked at by nurses, and that needs to change. We don't have enough SLPs in the health sector, within the acute wards, within hospitals. We don't have any in ICUs. This is where we should be. Our role is to assess any patient coming in with a suspected head trauma, with suspected dysphagia. So these are patients with head traumas, with cancers, with on ventilation machines. We are usually there as well with the neurologist, with the nurses, with the ICU doctors, as well as assessing their communication, of course. So we are a key part of the dysphagia team. And that is something that needs to be educated, I think, not only to the general public, but to the healthcare providers out there. We assess, we will develop a treatment plan. So what are we going to do? Initially, we can use compensatory strategies, postures that will help the patient eat, and then maybe do more treatment strategies. Diet modification, we will work with the dietitians and the nurses as well to make sure that, these patients are being fed. They're not placed on NG tube because they don't know what else to do with them. And so diet modification is important because we can have them have some form of normalcy where they can ingest, eat food, have a meal, enjoy that sensation of having food with their family, for example, rather than just shoving an NG tube or a PEG tube in the stomach, and just avoid a lot of different complications. So when we develop the treatment plan, we must be there, and we have to be working with the dietitians, which unfortunately here, the dietitians in the hospitals, I think work single-handedly without, I don't even know how they assign meals and diets to some of these patients. But I've seen some patients receiving very dangerous, meals for them. These are patients in palliative care, or they're cancer patients that can't swallow, and they give them things like crumbly chicken and like a salad to eat, which is very difficult to manage and to swallow, and it's very dangerous. So we have a lot of work, and we should be involved from A to Z with these patients. We also monitor their progression of dysphagia and their treatment. Are they doing well on the diet modification? Do we change the diet again? Do we, put them back on NG tube? Are they not doing well? So we are part of the dysphagia team. My final note here is just about our study. This was a big we took some patients, Parkinson's patients from Al-Adan Hospital so they were outpatients and they came to Al-Adan Hospital for a movement clinic. They were following up with a neurologist. They were just going back and forth for checkups, talking about their medications. So we decided, okay, let's screen some of these patients and see. And then we asked them some questions. Are you having problems, eating? Are you having problems with feeding? Are you having problems with specific meals? Do you notice or eating certain foods? A lot of these patients, unfortunately, had reported physical problems experienced while they are eating. So things like coughing, choking, sometimes drooling. They had their diets impacted. So they've noticed within the past month or so that they weren't eating certain foods. They've reported, things like, I stopped eating this, or I don't like to eat this because it gives me a lot of problems. A lot of problems means it's a red flag. And so these patients were not aware that they had dysphagia, and they didn't know how to figure out what to eat. And it was just sort of like a trial and error kind of process where they would try certain foods. If they are comfortable with them, they would stick to them and eat them. So what we found is that they had high or very poor scores on the quality of life measure. Their quality of life was diminished. And this was because of lots of things. Not only was it the eating, but they suffered from lots of depression. A lot of them clearly had depression, and they weren't seen by psychiatrists. Some were, and some were on medications, and I believe these medications were causing, again, some form of dysphagia. And so when we discussed with the neurologist and the nurse, are these patients being referred to any speech pathologists? No, they weren't. Were they being assessed for their swallowing? Did they report to you their swallowing difficulties? Nope, nothing was reported. So we did then a swallow test just to check. And we found that of those patients, 35% failed the water test. It was a simple water test, taking 15 ml from a cup, quick water. It's called the water test. If you want to look it up, they take it in one go. If they feel like coughing or choking, then they need to stop, and we time them for the efficiency and the timing of the swallow. 35% of those patients who said they know they don't have a dysphagia or they don't have a swallowing problem, in fact, failed the water test. So some were reporting changes, some were not reporting changes, but a lot of those patients that were not reporting dysphagia, when they were asked, they failed the water test. So there are a lot of patients out there with dysphagia walking around and they don't know it. Okay, key points. Dysphagia is the difficulty or inability in swallowing, which affects a person's ability to eat. Purposes of eating: we eat for nutrition and hydration, for pleasure, for quality of life. It's something we take for granted. Patients with dysphagia are unable to consume enough to maintain that balance of nutrition and hydration. And so they fall into this cycle of, poor health, poor recovery, longer hospital stays. If you look at, the dietary intake and the health status or nutritional status of patients and their length of stay in a hospital, you will probably be blown away. I think there's a huge correlation there that needs to be looked at and addressed. Because if you are not hydrated, if you don't have enough nutrition, if you are suffering health-wise, the length of stay in the hospital will be much longer. You will recover much slower, and you won't recover as well. So early detection is very, very important, and speech pathologists need to be on board for that. There are 4 phases of swallowing. Dysphagia signs and symptoms vary. So the list that I gave you, the choking, the coughing, this is a test, this is a list, but it does not fit every single person. Not every patient will have that list. We will have some silent aspirators. We will have patients that have temperatures and chest infections, and we don't know why. So we need to really, really think about what's happening with the patient. So watch out for those signals. So things like repeated infections of the chest, poor nutritional status, These all indicate some form of a dysphagia that's happening. And we play a major role in the team, in the dysphagia team, okay? In any medical team, actually. All right, my turn to ask you questions. Okay, first, maybe I should answer some of these questions. Is silent aspiration a problem? Can you talk briefly about laryngopharyngeal reflux and its effect on dysphagia? Laryngopharyngeal reflux, so any form of reflux that happens will ultimately cause lots of problems, because ultimately what will happen is anything that's being regurgitated back up will cause irritation, inflammation, and so that will worsen, of course, any problem that we have, specifically the dysphagia. So any form of reflux that happens can have that a very significant impact on the esophagus, on the anatomical structures that are being coated with that reflux material. What's the best way to help kids that have dysphagia due to paralysis and development? Well, that's a very broad question. Best way to help kids with dysphagia due to paralysis and development. I unfortunately don't have much experience in pediatric dysphagia, so I will leave that question. Can we rely on gag reflex on clinical diagnosis of dysphagia? And how can we differentiate between abnormal dysphagia and elderly difficult? Okay, so the gag reflex is important as part of an assessment. We don't heavily rely on it, no, and it's not the only thing that we rely on, but it is one of the indicators that, okay, there is possibly silent aspiration happening, that we need to watch out for. Now, how do we differentiate between presbyphagia and dysphagia? Dysphagia will lead to severe consequences, such as, chest infections, nutritional status deficits, but the presbyphagia will not be as severe as the pure dysphagia. And as well, if you look at the diagnosis of a patient, if there's anything co-occurring as well. What is your point of view regarding the new evidence that states absent gag reflex is not a predictor of dysphagia? Yeah, there's a lot of controversial literature out there. There are lots of researchers that will agree and some will disagree. For example, there is also talk about looking at the SpO2 levels during the assessment of a swallow, which is the oxygen saturation levels while you are assessing the swallowing. Some believe that a drop in the SpO2 level indicates possible silent aspiration if there is no, overt coughing or choking being noted. And so there's that school of thought where an absent gag reflex is not a predictor of dysphagia. I think as part of a process of the assessment, it can give us a good indication that something is happening. But as I said before, it is not something that I rely on completely or on it, or just solely on the gag reflex. So I have to take into consideration lots of other things. Can we do any swallowing assessment without conducting MBS or FEAS? Yes, an instrumental approach. Typically, no. What I know from my limited experience, what I know is usually these are the two ports of call when it's instrumental. It's a modified barium swallow, any kind of video fluoroscopy, or a fiber optic endoscopic exam. Otherwise, it's a clinical exam or a screening test, which precedes that actually. What is the frequency of respiratory complications? That's a good question. I don't have the data on that. The frequency of respiratory complications after video fluoroscopy of swallowing. Typically, I wouldn't know if there is any such thing like a study on that. I'm not sure. I mean, you can look at that up, but typically what happens is if on video fluoroscopy we find that the patient is aspirating, we would stop the consistency, or we would stop the exam that we are doing. So we try to keep them as safe as possible. And whatever it is that we are giving them, it is in small amounts. It is not like them chugging food or liquid in. What about treatment? I did not have time to cover treatment. So treatment and management, if you are still interested, we can do that as a part 2 of the lecture, because as you can see, I've already reached 2 hours just talking about the other topics. How much amount of food is still considered safe? There's no such thing, Sarah. How much amount of food is still considered safe in aspiration and won't cause aspiration pneumonia? We don't talk about the amount, we talk about the consistency of the food. So a person that aspirates on liquid cannot have liquid. We need to thicken the liquid, okay? So they will not be safe on any amount of liquid. So we stop that consistency. So this is typically how we operate. We work on consistencies. Are they safe on liquids? Are they safe on solids, semi-solids? You know, honey thick consistency, pudding consistency, not the amount. There's one more question. Where can we practice MBS or FEAS? In our region, I believe Saudi Arabia does a lot of training. They bring lots of experts. I did my training in the US. So I went to Boston. I did my training with Susan Langmore in Boston, and I went to Cincinnati Children's Hospital. So I went all the way to the US, but I am sure that they do arrange things here in the region. So keep an eye out for things posted by JISH or the Speech Pathology Association of Saudi Arabia. They are on top of things. They have things happening all the time if you are able to go to Saudi Arabia. Thank you.